Devi. Great, well, good evening and a big welcome to the Blavatnik School of Government for those of you coming for the first time. My name is Nairi Woods and I'm Dean of the school. It's a real thrill to have these two scholars here this evening. One of the biggest joys about being an academic is the opportunity to supervise outstanding research. And in these two scholars on the stage, it's been a huge privilege to supervise at least some of their outstanding research. So let me introduce our two speakers here this evening who have written an incredibly important book. It's called Governing Global Health, and you'll all be thrilled to know that you can purchase your own copy in the cafeteria over glasses of wine right after the event. So I'll look forward to seeing you there with your own copies. No one steals mine. So on my right is Devi Sridhar, who completed her doctorate here at Oxford in medical anthropology in 2006, a doctorate that was then published as a book called The Battle for... The Battle Against Hunger, and traces the World Bank's responses to the problem of malnutrition. And throughout that work, Devi grappled with, and it's a brilliant book to read, the drivers of the World Bank's responses to that particular health problem, and in the course of that, to understanding how that particular international organization responded to health. On my left, Chelsea Clinton, who completed her doctorate here at Oxford in 2014, wrote a brilliant doctorate on the Global Fund, probing whether this new experiment in global health governance actually resolved the profound problems that it set out to solve. I promised each I would say something about them they wouldn't want me to say. I'm going to quote, Chelsea's doctorate was examined by two of the toughest examiners in Britain, and it was described by them as exceptionally thorough and thoughtful, as fascinating, creative. It's a terrific piece of work and a huge contribution to scholarship. What can I tell you about Devi that she doesn't want me to say? Devi was the world's youngest Rhodes Scholar when she was made a Rhodes Scholar, and she's now, I'm sure, the youngest professor at Edinburgh University. She holds the chair in global health at the University of Edinburgh, where she's building the most important centre for thinking about global health governance in Britain. So we're incredibly lucky to have Devi and Chelsea here with us tonight to present this book, an important investigation into how does global health governance work? Can it do what the world needs it to do to help resolve both chronic disease and pandemics? Enough from me. I'm going to turn it to Chelsea and Devi to present their book, and then we'll have time for questions immediately after that. Thank you, and thank you for joining us this evening.
So first, a huge thank you to the Blavatnik School for hosting us. And we were just talking about earlier what a special place Oxford was and how we really treasure the years that we had here. A little known fact probably Nairi doesn't want you to know is that she was my first boss in Oxford. I worked as her research assistant in 2003 and celebrated my 21st birthday with Callum. And I'm slightly frightened that my PhD supervisor, David Gellner's here, and lots of friendly and familiar faces. So just a huge honor to that, and also to OUP and to the staff at Blavatnik for hosting us.
I just want to echo my gratitude to Nairi for being such a tremendous doctoral supervisor, but also for introducing Devi and me. We quite literally wouldn't be here without you. And so we are so grateful for the mentor and the friend that you have been to both of us throughout our careers and really our lives. We want to thank everyone here at the Blavatnik School, particularly Jolie and all who work so hard to kind of make this possible. We want to thank Ben in the back for making sure our microphones work. And we certainly want to thank OUP across the street for having faith in this project and in us. And really just, it's great to be back in Oxford, and we're thankful to Nairi for giving us the excuse to be here today to talk about our work.
Great. To start off, to say that it's a bit of a funny time in the world to be talking about anything global. We have a book that's called Governing Global Health, and so did some reflections on what does that mean in terms of how we advocate for health issues across the world. The past few decades have been called the golden age of global health. More and more money, more and more actors, more and more initiatives, things are getting better. And through that time, you've had different justifications. Why should we invest in health? Some have been moral, it's the right thing to do. Some have been about economic logic. If you do this, you're going to improve productivity, you're going to increase economic growth. And increasingly today, because of this focus on America first and Britain first and each country to itself, it's been about security. In global health now, if you read headlines, it's new threat coming, watch out for that, watch out for antimicrobial resistance and these kind of arguments. And so we're really moving towards a very securitized framing to global health and a justification for why invest by saying, oh, might come here and this is, and so I think we just wanted to start off by saying actually the real challenge of global health is not the outbreaks that you read about in the media. It's not the headline grabbing, new superbug. It's actually child poverty, it's about malnutrition, it's about clean water. And just to highlight childhood pneumonia, which kills close to 1 million children a year. So when we think about global health, it's important not just to think about, this, which is what Times Magazine cover was last week, but also to think about the broader context of health challenges we face. This was Times Magazine's cover saying, we're not yet ready. And these are headlines that we've faced in the last couple months. And it's strange that we're not ready because actually the whole history of cooperation in global health has been about infectious disease, and actually governments coming together since the 19th century to say, how do we deal, now that we're starting to have trade routes and work together to actually deal with infectious diseases. So it is puzzling from that perspective that we had an Ebola outbreak. So the Ebola outbreaks, some of you might know a lot about it. For those who don't, it was an outbreak in West Africa that triggered global panic. It was actually one of the most Googled terms on Google in that time, around that time in the States. And it was seen as a real failure of the international community, because before that, Ebola was something that was only dozens of cases, easily managed. So how, in fact, did we end up having over 10,000 people dead from this? And because of this, there was increasing attention. Am I not pressing hard enough, or do I need to stand here? There we go.
Someone else is now managing.
Okay, someone's going to manage it. Okay. The World Health Organization. So the World Health Organization was set up to do this. And so people looked to the World Health Organization and said, how did you mess it up so badly? And the New York Times won a Pulitzer Prize for their coverage showing all the ways in which the WHO dropped the ball with Ebola. And Margaret Chan, the Director General, even said herself, we failed in Ebola. One of the reasons they give for the justification of why they failed in different reviews, and there's been like a number of reports, and there have been reports about the reports, and there have been reports about why nothing's happened about those reports. We're in a cycle kind of this, is financing. Saying, oh, there's not enough money. If we just had more money for global health, we could solve this. But actually, if you look at what's happened in terms of financing, there has been more and more money into global health, peaking in 2013. So the problem is not that there's been a lack of funding over the past 20 years. It's more intricate than that, and that's kind of one of the puzzles we wanted to look at, where we're having all these claims of not enough money. But actually, we've had quite a lot of money going into global health. And so we started to pick apart where is that money going. And we looked at the four institutions of the World Bank and its health portfolio, the World Health Organization, Gavi, it's the Vaccine Alliance, and the Global Fund, which fights 3 diseases. And you start to see that these are new initiatives. They were established post-millennium, and that they're actually attracting quite a lot of resources. And this was manifest most clearly in the same week when Global Fund donors pledged nearly $13 billion to help end epidemics. So seeing this being a huge success, they raised $13 billion in 1 week from donors. When WHO announced a plea for funds for Zika, and this was at the peak when microcephaly, what babies are being born with microcephaly, it's declared an emergency, they asked for $122 million. And in fact, they only ended up getting $14 million. And so there's a question there, not about there not being enough money, but why that money is not being channeled to certain institutions. And that's what we wanted to start to unpack. So I mentioned the 4 institutions we look at in the book are the WHO, the Bank, the Global Fund, and Gavi. And what we're interested in, and the argument that we make, is actually there's been a shift in how we actually deal with health challenges at the global level. A major shift away from the old institutions, WHO and the World Bank, to the new ones, the Global Fund and Gavi. And we use something called principal agent theory to help explain this. And actually, we're very in debt to Nairi for this because she's the one who introduced us to this theory and said you should start looking at this and to start unpicking these issues, because it's really hard otherwise to make sense of it. And principal agent theory basically says that you have different stakeholders, governments, foundations, NGOs, who delegate to an international organization, to one of these 4, to solve a problem that they can't solve on their own. And when they delegate, they do so with certain, you could say, conditions or certain objectives in mind. And so with this in mind, this really helps to start to think about why are funds channeled through certain mechanisms and not others, who's doing that channeling, and for what reasons. So I'll hand over.
Yeah, and so kind of to help illuminate kind of the answers to those questions, and one thing we do in the book is to focus on what are the key differences between kind of the old institutions, the post-World War II institutions of the World Bank and the WHO, and then these newer institutions, Gavi, which is focusing on closing the vaccine gap, and the Global Fund. And one of the kind of core differences really relates to kind of what are their respective mandates and missions. So, for example, if we look at kind of the WHO and the World Bank, they have quite broad mission statements. The WHO's kind of mission statement, as codified in its constitution, hasn't changed since the WHO's inception. It's to help all people kind of attain the highest possible level of help. The bank's mission statement has evolved, but this has now been kind of its clarion call for decades, that it is focused on alleviating poverty and improving quality of life around the world. Kind of the juxtaposition is pretty stark to the more problem-focused mandates of the Global Fund and Gavi. The Global Fund to attract and disperse more resources to combat its 3 constituent diseases, HIV/AIDS, tuberculosis, and malaria, and Gavi to ensure that all children everywhere are vaccinated, particularly those living in poor countries. This somewhat goes to the origins of the Global Fund and Gavi, which were really around the recognized market failures in childhood vaccinations and in the prophylaxis and treatment for HIV/AIDS, tuberculosis, and malaria. Kind of that there were big discrepancies that were seen back to kind of what Devi was talking about, not only as moral quandaries, but really kind of security crises. And those kind of led the world to experiment with these new models. And the experiments kind of weren't only in these more problem-focused mandates to respond to diagnosed market failures. They were also in the governance of these institutions. So if we look at the World Bank and the World Health Organization, you might think this is just the same chart repeated 4 times. It's not, actually. If we look at the top 2, it's the World Health Organization, kind of who's in the World Health Assembly, the ultimate governing body of the WHO, and it's all 194 member states of the WHO. If we look at the Executive Board, which has about 3 dozen seats on it, charged with kind of the more day-to-day oversight of the WHO, it's also all member state representatives. It's a similar story if we look at the World Bank on its board of directors and board of governors, also all member states. It's quite different when we look at who is comprising the Global Fund and Gavi's board. If we look just kind of at the Global Fund board voting members, we see, yes, 3/4 are still states, but importantly, it's an equal balance between donor and implementing countries. Implementing countries is the vernacular the fund uses for recipient countries. But also on the board is a private foundations representative. Admittedly, that's a euphemism for the Gates Foundation. NGOs from both the Global North and the Global South, a private company representative, and someone representing affected communities, so someone living with HIV, kind of endemic tuberculosis, or someone who's had malaria. The Gavi board is even more diverse. It similarly has an equal representation of donor and implementing countries. It also has a vaccine industry represented on its board, a representative from the vaccine industry in donor countries and the vaccine industry in developing countries. It has academic vaccine research partners on its board. It has 9 independent individuals on its board who are not otherwise represented by board stakeholders. And what this kind of demonstrates is that by kind of the new millennium, there was a broader understanding of governance, kind of that there was not only kind of a need for states to help kind of set the agenda and the strategy around global health, but also to enfranchise those who are largely doing the work on the ground, kind of NGOs, but also increasingly funding that work, private foundations, and even to a lesser extent, private companies. And particularly for the global funds perspective, it was important that it kind of demonstrate in a normative way that it was listening to kind of its ultimate stakeholder, those who were affected by its 3 diseases. But a big shift, one that's also reflected in the ways in which these organizations fund or work on the ground. So the bank lends directly to governments. The WHO largely works directly through governments, whereas the Global Fund and Gavi both work through multi-stakeholder partnerships on the ground, and actually their grant applications require that those partnerships be constituted and demonstrated to even apply for funds. A third difference relates to who pays for the institutions. So historically, international organizations relied both on assessed membership dues, kind of what their member states were expected to pay, kind of aligned with the right of membership, and voluntary contributions, kind of what states wanted to pay to help promote certain priorities. But increasingly, kind of we've seen a shift more toward the latter, including at WHO. So starting in 1980-81's budget cycle, more than 50% of WHO's budget has actually come from voluntary contributions, not membership dues. Why is this so important? Well, if we look at the next slide, we see there's a rather finite number of significant donors on a voluntary contribution basis to the WHO. And 93% of what is voluntarily contributed to WHO is earmarked. So while kind of one of the original logics for international organizations would be that they would create a forum for member states to gather and debate and then agree on priorities collectively and then kind of collectively fund those priorities. Increasingly, we're seeing at WHO, it's a few large donors that are driving the agenda of what WHO is focused on, but also what it's not focused on. If we look at the World Bank, IDA, which focuses on lending to low-income countries and is 100% funded by voluntary contributions only from states because non-state actors, philanthropies or corporations or individuals cannot contribute to IDA. But if we look at kind of who the major contributors are to IDA, it's a not dissimilar list from what we saw, with the exception of the Gates Foundation not being on it and Japan being on it, as to who are the major voluntary contributors to WHO. So if we look further at kind of where the bank is increasingly spending its time, it's also increasingly spending its time on managing trust funds. So trust funds are funds including from the Global Fund or the Global Eradication of Polio Initiative or the Global Environmental Facility, if we think kind of outside of the global health paradigm, that are entrusted to the fund, entrusted to the bank, kind of where the bank acts as a fiduciary agent. As one example, the bank has managed now more than $30 billion for the Global Fund alone. It has no discretion over how those funds are ultimately invested by the Global Fund, but it increasingly takes a not insignificant amount of time and resources for the bank to manage. So a maybe not obvious, but still important way in which kind of donors or other priorities are shifting how kind of the bank can possibly spend its time. Again, kind of looking at kind of a graph in a different way that Devi showed earlier, we see kind of the stark flatlining of the WHO's core budget, which has increased only as new member countries have come in. That's what accounts for the slight uptick. And then really at the green and the red lines showing kind of the World Bank trust funds and the WHO voluntary budget kind of swamping what the WHO itself has discretion over. Looking at the Global Fund kind of tells a similar story of who its major donors are. And while the Global Fund was set up in part to raise additional funds from hopefully additional donors, largely it's been bilateral donors and the Gates Foundation. More than 95% of kind of non-bilateral funds to the Global Fund come from the Gates Foundation. And if we look at Gavi, while the Gates Foundation is much more important to Gavi on a relative basis than it is to the fund, it similarly is meaningfully the only non-state donor to Gavi, and once again, it's a kind of similar group of countries. So even though kind of for these motivated reasons around diagnosed market failures and wanting to have cooperative mechanisms that reflected a broader understanding of stakeholdership in global health governance in the 21st century, kind of that catalyzed the origins of Gavi and the Global Fund. In many ways, kind of the principles are quite similar to what we see at both the bank and WHO. A fourth key difference is how easy is it to monitor what these institutions do. Kind of one of the kind of easiest examples is to think about kind of how these institutions are set up. Both Gavi and the Global Fund only exist from an organizational or operational standpoint in Geneva. It's very different than kind of the WHO that has more than, I think, 180 country offices around the world, or the bank that has more than 150 offices around the world. It's much easier for kind of donors to monitor kind of what Gavi and the Global Fund are doing, not only because of their narrower mandates, but also because they can just fly to Geneva. But similarly to a different understanding of stakeholdership, kind of by the 21st century, there was also a different understanding of transparency and the important role that transparency played in kind of building trust, but also in providing accountability to donors and to the public more broadly. So kind of from the beginning, the Global Fund has published both successful but also unsuccessful grants. It's published the scorecards of those grants. It's published extensive information about its own finances. It's published extensive information about its own organizational assessments. It's published extensively its own inspector general's, even originally confidential reports. Gavi also has been quite transparent from inception. It hasn't published unsuccessful grant applications, but it's published kind of everything else that the Global Fund has. The bank, which historically was notoriously opaque, since 2010 has had an open information policy in which it now is very clear about what it publishes and what it doesn't. It's slowly working kind of through its backlog of tens of thousands of loans and credits to put online kind of what it has funded over the years and kind of what its programmatic scorecards are. There still is not a lot of financial information, and there's a dearth of subcontractor information, but the bank has gotten much more transparent, arguably because of how Gavi and the Global Fund shifted kind of the standard and the expectations of what international organizations would disclose. The WHO remains still quite opaque. It is the only organization that we study that doesn't report to the International Aid Transparency Index. It's the only organization that we study that doesn't have a systematic way of reporting on kind of programmatic effectiveness or even efficiency. It doesn't publish an annual report. And so while it kind of trumpets its transparency in some ways, you can all watch on live stream the World Health Assembly in less than 2 weeks if you want. It doesn't publish kind of what happens at the executive board meetings in closed session, which is the majority of the executive board's time. It doesn't publish what's on the agenda. And so it still very much is kind of living in a 20th century paradigm of transparency and accountability. And just kind of the last point to make is one of the reasons the Global Fund and Gavi were created was the hope that they would be nimble, both nimble in being able to respond to shifting needs on the ground and around their work, but also nimble to respond to kind of donor preferences, admittedly, as well as to kind of when reforms may be kind of diagnosed and needed. And we have seen that. Gavi actually started off as 2 institutions, one that was focused on kind of fundraising to fund the work of the other. In 2008, those merged together. The Global Fund underwent a series of significant reforms, both in governance as well as in the ways in which it interacted in a more sustained way kind of with its implementing partners from 2011 to 2013. Despite the crisis of Ebola, the WHO has not reformed, despite all of the kind of papers and the 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 papers that Devi referenced, including work that we have done together. WHO kind of looks today as it did kind of before the Ebola outbreak in Guinea in December of 2013. And so kind of what we hope kind of this book does in part is to help kind of highlight why we think there are lessons to be had from what has worked, but also what challenges the Global Fund and Gavi have encountered kind of for kind of their older sister institutions in the constellation of global health.
Yeah, so to start wrapping up, why does the global health system look the way it does? And this is kind of how our book starts to end up, which is saying that there's actually a logic and there's a rationale to why things look the way they do. And when we see this proliferation or we see more and more initiatives, we need to think about why we're seeing that and not just say, oh, this is all happening and it's all random and it's, you know, there's nothing directing it. And the shifts we identify, again, from principal-agent theory are due to key donors wanting, and there are four things. First, to align the objectives of global agencies with their own objectives, which are very easy to do when you develop new institutions that have mandates that are very close to your priorities, or you earmark your funds to the existing ones so that you basically sidestep any kind of decision-making. To create incentives, you want to be able to reward if they're doing things you're happy with, or to punish if you're not. And how can you reward and punish these kind of agencies? One is pulling funding very quickly, and you saw this with the Global Fund when there were the first kind of smoke coming out. There was corruption occurring. Immediately, key donors came in and pulled their funds and said, we're not going to have them there. How else can you punish an agency? You can get rid of the head. We have seen this, where actually you've had very swift leadership changes in the new partnerships when, key principals have been unhappy with how things are going. You want to monitor what they're doing. You don't want to have to visit, 60 offices to get a sense. You want to go to Geneva, you want to see what's there, and you want to be able to have it in a format that's digestible. And finally, and this is applicable to the Gates Foundation, and we should not underplay the role of the Gates Foundation. It's hugely, hugely important in all of these developments, is direct voting power. You don't want to be on the sidelines. You don't want to be an observer. You want to be actually voting and at the table. So if we start to think about our conclusions to who runs the world, the very kind of provocative and big question, the role of who runs the world in global health, our conclusion is that three actors, the United States, the United Kingdom, and the Gates Foundation, dictate a lot of what's happened over the past few decades and in these shifts that we've seen. These three actors, and it's not just in financing, it's in a myriad of other ways, and we kind of go through those ways. The other question we often get asked is about public-private partnerships. These are seen as a solution to everything. Everyone says, like, oh, we could use this for universal health coverage, and we can use this for NCDs, and we can use this for cancer. And so we look at, actually, when can you use this kind of model? What are the positive aspects of this model, and when are the drawbacks of actually using this type of model, so that you don't just use it as a one-size-fits-all. There are certain health issues it can work for, and it's others that it's not so suited. And the final thing is about reform. It's the constant thing that I guess we've all been hearing about for decades. How do we fix the UN? How do we reform the World Bank and the WHO? And so we detail specific ways that we think that these agencies need to reform for the World Bank and the health sector and WHO more broadly. And so that you actually have trust that when you do make a plea saying there's an emergency, we need funding, we need to respond, that actually there is a response and people feel that you're going to deliver on it. And we outline those. In case this has seemed a bit depressing, because you might have thought global health over the past 2 decades has been about country ownership and about more and more initiatives, and it's actually been about more concentration of power and using more channels of few actors to influence, Chelsea's going to end on a positive note.
Optimistic note. And a more optimistic note, and also sort of arguably a coda to the second conclusion that Devi mentioned. We are often asked kind of what can public-private partnerships solve? Like, should we be constructing a new PPP for NCDs or universal healthcare coverage, or investing in actually building meaningfully resilient and robust health systems? And one of our responses is to not only kind of talk about the analysis of our work, but to say sometimes public-private partnerships don't have to be codified in a secretariat in Geneva, because we actually have a pretty powerful example of an informal alliance of a public-private partnership that has made a tremendous impact in the last 3 decades in the world. In 1988, at the World Health Assembly, the WHO, the US CDC, Rotary International, and UNICEF came together to form the global eradication of polio initiative. It might kind of seem infeasible or kind of unimaginable, but in 1988, polio was still endemic in 125 countries. There were still 350,000 people who got polio every year, tens of thousands of whom who were left disabled. And so the world really came together with very clear objectives for these four kind of founding partners, kind of who would do what. And now, kind of fast forwarding almost 30 years, there's so much coverage on kind of the persistent existence of polio, and that is important. But I think it's also important to look at kind of where we've come. So additionally, with the Gates Foundation joining the partnership, more than $10 billion has been marshaled kind of to fund this effort. That has meant more than 3 billion children have been inoculated against polio, largely relying on more than 22 million voluntary healthcare workers. So that's, I think, a pretty extraordinary achievement. Again, in something that's had a narrow mandate, kind of with the clear delineation of responsibilities and a significant upsurge of funds, but one that wasn't kind of constituted in a formal way. And so we hope that kind of by ending on that, it says that not only do we think it's important to kind of look at the experiences of the Global Fund and Gavi, but to look at other models that may be useful as we look at the SDG agenda and the still, as of yet, unfinished work in global health. So just again, thank you to Nairi and to the Blavatnik School. We'd welcome any and all questions. Thank you very much.
And now to questions. There's a microphone circulating, and please just tell us your name and perhaps where you're from as before you tell us your question. Yes, can we have a microphone to hear?
Les Klein from Abingdon.
Right.
You talked mainly about where the donors and the funders were distributed from. Can I ask you a question to do with the countries that are helped? Specifically, is China helped very much by any of these four organisations? And if not, is that because, so that's a guess there, if not, is it because they don't need the help, or might they be suspicious of what they might see as four organisations which are Western-led or dominated?
Great.
Yeah, that's great. Do you want to start?
So actually, it's probably going to surprise you, but China is one of the largest, if not the largest, I check it was either one or two, recipients of Global Fund grants. Some say that actually, and there's been a large debate, like should China be for this Global Fund that was set up for HIV, HCV, and malaria, should the funds be going to China? Should they be going to India? These are both in the top 5 in terms of recipients. And the arguments given for why they continue to fund there is actually having to do with governance. They say that the way Global Fund grants are given, you have to include civil society. They're called country coordinating mechanisms. So there's an argument being made that actually if you make grants contingent on actually a country coordinating mechanism, you're kind of helping civil society thrive. Of course, what leads is you have state-sponsored civil society, so there's a ways to get around it. And the other reason that they push for it is that many times, and this is why they've given grants, for example, to Russia, is that the groups that are most affected by HIV/AIDS are not groups that actually governments want to spend their resources helping, so they end up being left behind, the most vulnerable groups. So you can think of injecting drug users and so on. And so the Global Fund says, okay, we'll come in and give our resources because we know the government's not going to do this, but they will do it if we give the funds.
And kind of to build on what Devi said, kind of the ways in which eligibility is determined, kind of as who qualifies to apply for grant funds, varies quite significantly across the organization. So for Gavi, it's a pure kind of per capita income calculation. There are now about 72 countries, I think, that are Gavi eligible. One time there were 77. It says something about kind of what's happened in the world economy in that it actually dropped below 70, and now there are a number of countries that had graduated out of Gavi eligibility. I always think that is the cruelest use of that verb. You know, if you graduate from Oxford, it's a huge deal, like congratulations, you graduate from Gavi. It means like you're maybe $1 above the cutoff because they have been very kind of conservative in maintaining their income threshold. They've made no exceptions. So I always think it's an odd use of graduate. But for the Global Fund has a matrix of income and need, where need is determined largely by the incidences of tuberculosis, malaria, as well as HIV/AIDS, but also kind of the Global Fund's own kind of diagnoses of kind of what those governments themselves may not do. So we've seen this probably most acutely in Russia, because Russia kind of made a rather stated move away from kind of funding both tuberculosis treatment in prisons, as well, which has really come back to haunt them with kind of the explosion of multi-drug resistant tuberculosis, and funding HIV, both prophylaxis and treatment for injectable drug users. And so the Global Fund has a more kind of flexible, and they would also argue nimble, kind of back to their origin kind of ethos in how they think about who is eligible for their funding and why.
Next question. Yeah, can we come right to the front?
Hi, my name is Nora. I am part of the MSc program in water science and related to like water health and issues like that. A lot of the literature that we've basically focused on is the idea of the World Health Organization versus like community-led health objectives and dealing with local crises. You touched a little bit on it. Do you mind expanding on what you feel the benefits are of having, say, a World Health Organization-led project to tackle an epidemic versus like local community-led leadership?
Yeah, I think that's a great question. Chelsea, you looked in your thesis at, because when the Global Fund was created, the idea was not to create an elaborate mechanism of lots of bureaucrats in country, but rather, as Devi said, to use the country coordinating mechanism so that the country itself would be in charge of its own policies. But what was the result on the ground?
So if we look at the ways in which country coordinating mechanisms have kind of actually manifested over time, you often have kind of the major donors to the Global Fund, who are also often the major bilateral donors to those countries, sitting on the country coordinating mechanism. So you have kind of the US PEPFAR person who's at that kind of embassy, or you have kind of the German Development Agency kind of designee at that agency, or kind of particularly in the Francophone countries, because France increasingly has moved its bilateral aid funding to focus on the Francophone countries. And so there's certainly still a donor engagement effect. And I think because of that, if you kind of survey kind of health ministers or finance ministers who are on the receiving ends of these funds, kind of whether from the Global Fund or the bank perspective, they say they really don't see a major difference between the Global Fund or the bank. That's not true so much in Gavi, because in Gavi it's so specific. And so kind of they see kind of where the Gavi funds are going to kind of buy the immunizations kind of through UNICEF that show up literally in these kind of huge parcels with UNICEF and Gavi kind of stamped on them. And there's not that same kind of expected ongoing engagement. And so I think it has not really achieved sort of what the funders initially kind of said were their objectives, to kind of have meaningful country ownership of the initial kind of focus of the grant, but also the delivery of the grant and the assessment of the grant.
And Devi, does it matter? Does it matter whether it's the country that decides what its health strategy should be, or whether it's the group of donors that you've looked at in the book?
Yeah, it matters hugely, and I think I'll just take one example, which is about priorities. One of the things that you might think of is, okay, whose priorities are actually being funded, and the priorities being funded are those of wealthier countries and wealthier actors. So for example, if the Gates Foundation says, we're not going to do NCDs, and they don't fund it, and they're actually dictating a lot of what's happening in international institutions more broadly, it crowds out space for anyone else to do this kind of work, and you see it with the financing and the action. And then it becomes...
NCDs meaning?
Non-communicable diseases. So this is kind of often for all the things that are non-infectious. So for example, cancers, heart disease, diabetes, these are the things that actually kill most people. We are aware of that here in high-income countries, but actually it's a growing problem in low and middle-income countries. And recent analysis has come out from the Institute for Health Metrics and Evaluation in Seattle that basically this should be a priority for all countries across the world, except for parts of sub-Saharan Africa, which are still more concerned in terms of burden, and burden is not the only metric, but burden in terms of child deaths and child mortality.
I think kind of just to give a snapshot to kind of elucidate why what Devi said was so important. If we kind of look at a DALY basis, a disability adjusted life year basis, kind of which is the way in which we try to standardize kind of morbidity and mortality around the world. It's also kind of what the NHS uses here to determine whether or not kind of to approve kind of new therapeutics or treatments or not. If we look on a per DALY basis, more than $1,000 kind of per DALY associated with HIV/AIDS is invested kind of by global donors every year. Kind of the commensurate level for malaria is more than $600. For NCDs, it's about $3.60. But we know that NCDs kill 54% of the people who die every year in low and middle income countries. So kind of the misalignment of priorities isn't kind of a slight misalignment to the burden of disease. It's actually quite a stark one. And one of the challenges kind of that we're seeing play out in real time is many of the countries that have benefited and will absolutely be the first to say they're incredibly grateful for the PEPFAR funds from the United States that kind of were crucial to helping turn the tide against HIV/AIDS, are saying, you know, clearly you believed in us, whether us is kind of Rwanda or Ghana or Malawi, kind of to give us these huge grants of money to fight AIDS. But now, kind of a big study came out yesterday in the Lancet. Now, kind of people are living kind of 10, 12, 15 years longer who are HIV positive, but they're getting sick of cervical cancer or heart disease. Kind of, can we use some of these funds to help build our health system? And right now, PEPFAR has said no. And so kind of this is not just a theoretical debate or one that's illuminated by the distribution of funds at a global level, and it's very much kind of unfolding kind of in the country context around the world.
Just one thing to that, which is about Ebola, that out of the response of Ebola, there have been all these questions of like, how did it go so wrong? And one of the things was that they didn't even know for 4 months that it was Ebola because the health systems were so poor in Guinea. And if you look at the pictures, you can understand why, that they didn't know what it was. And so there's that question, okay, how do we prepare for the next outbreak? So people are saying, okay, let's do complex modeling. Let's model for what the next 3 things are, the next 5 things are, and let's develop the vaccines. And that's hugely important. We should be doing it. But actually, Ebola and Zika would not have been on any of those lists. No one could have predicted those. So what you actually need is stronger health systems. And these donors, still today, I mean, it's taking baby steps, are not investing in health systems. They're not invested in basic systems that can detect what the next thing is. Instead, we're still focused on what we think through modeling could be the next thing, and then developing the commodities or the kind of, drugs to treat it. And so it's, that eliminates.
Terrific. I'm going to take 3 questions. We'll start testing their memories, shall we? JP.
Good afternoon. My name is Jonathan Padilla. I'm from the great state of California. I'm a student here at the MPP program. I guess my question would focus on the role of public-private partnerships. How, given the previous points raised by our speakers, how does the WHO and other institutions work with the private sector to ensure that research opportunities and these types of programs that might not be priorities are actually getting funded and research is being done and systems being developed on that front?
Terrific, thank you. And then if we can have the microphone through to here. Gal.
Thank you very much. I'm Gal. I'm a student here as well. You focused a lot on funding and allocating resources to current solutions that exist. I wanted to ask, what do you think is the role of innovation and finding new solutions, cheaper, more effective solutions, and whether you think that current institutions give the right incentives to do that?
Great. And Dan, and just, if you can pass the microphone to this lady here.
Hi, I'm Tiggy. I'm a visiting student here, originally from Princeton. So my question is, while it's clear that financing and financiers play a crucial role in influencing the supply side of the global health agenda in terms of provisions and resources, I'm curious to know what you think of the impacts of the media and cultural movements on the demand side of global health promotion efforts, like we can see in terms of the rapid spread of vaccine refusal in the media and the formation of vaccine cluster networks, and then if the media can be incorporated in the principal agent model that you developed.
Great. Well, let's have a go at those. Which one would you like to start with?
Sure. Well, I'll start with the last one and try to work my way backwards. I think, as you kind of saw from the Time magazine cover, kind of the media absolutely plays a role in kind of setting what's on the kind of agenda for the public in donor countries, and that certainly influences kind of what does get invested in. So just a couple of examples of that. Really kind of the HIV/AIDS activist groups in both Europe and the United States were hugely important in making the moral case that it was just immoral, kind of that AIDS was being rendered a chronic disease in the 90s in places like Princeton. But kind of in the late 90s, fewer than 50,000 people in sub-Saharan Africa were on antiretroviral therapy, partly because it cost somewhere between $10,000 or $12,000 per year, and you had more than 2 million people dying every year. And kind of that sense of global solidarity was hugely important in kind of putting on kind of the agenda of the United States and kind of the UK, the French, the German governments, where there were very powerful kind of activist groups that it was no longer good enough to kind of treat people in their countries. Kind of there needed to be a global movement to treatment, and Kofi Annan kind of really helped kind of broaden that out and say, actually, we need to be treating kind of what he termed the diseases of the poor. And he gave a series of speeches around the world to try to do that, arguably speaking kind of through the media, kind of to the stakeholders who he needed to sell on this, kind of in Washington or London or Berlin. So I think absolutely kind of you're right.
That world's changed a bit.
Yes.
You know, those were the halcyon days when UNAIDS or the United Nations could say, here is a problem and here its solution. But we've seen a real collapse in trust of those big institutions and their wisdom and what they say about how to do things, and an explosion of different kinds of new media. You know, look at, you know, we've watched in dismay as Andrew Wakefield has imposed himself on the United States and persuaded communities not to vaccinate against measles. Children are dying. How do we deal with that? You know, is that demand side, which was positive in the example you gave, now a real challenge for global health governance?
Well, I was going to say that's the positive, and then kind of somewhere that sits kind of in a less kind of clear, kind of a more ambiguous state is what we saw happen around Ebola, because kind of once Ebola was recognized, whether it was kind of the head of the CDC or the head of MSF or the head of Partners in Health or the health ministers, kind of more admittedly in Liberia and Sierra Leone than in Guinea, saying, you know, we need help. It wasn't kind of really until someone came into the United States who had Ebola that all of a sudden the U.S. government was like, oh my gosh, we need to give money to this, and oh my gosh, we need to kind of deploy the U.S. military, because epidemics largely are logistical challenges, actually. There's a reason why kind of the U.S. and the British military are continually deployed in emergency situations, whether kind of earthquakes or epidemics, because they are kind of logistical challenges kind of that need a logistical as well as a kind of public health coordination solution. And that was largely driven by kind of first social media, and then got picked up kind of by broadcast television. But it was first social media where all of a sudden there was this like great panic, Ebola was coming to the United States, like, oh my gosh, everyone needs to stay inside. I mean, it was really kind of wildfire. And then we think about kind of Andrew Wakefield, thank you so much, Britain, for giving him to us, who is doing horrific damage, as we're seeing in the current measles outbreak in the Somali American community in Minneapolis, where we now have had 50 cases of measles, 47 of which have needed to be hospitalized. 46 of those 47 are children under the age of 17. Right? So this is completely outrageous, and I think, you know, it's a question, Nairi, that you asked that kind of we're thinking a lot about. We were talking to Peter Piot and his wife Heidi, who is kind of one of the experts on on immunizations around the world about this last night after our event at the London School. How do we kind of rebuild both kind of those bonds of trust so that kind of parents understand that no, immunizations do not cause autism. Yes, measles is quite scary and can be lethal, but also to wealthier parents, at least this is true in the United States, and I don't know if this is true kind of in Britain or elsewhere, but very much kind of we have a lot of kind of sociological and anthropological research that now says that for wealthier parents, it's not actually kind of that they're worried about autism so much as kind of there's this focus on purity, and they're clearly free riding on herd immunity. And so we have now kind of wealthy neighborhoods in Los Angeles where barely 50% of the kids are vaccinated. It's hugely dangerous. That's a massive public health vulnerability. So it's both about building trust, but also kind of reconstituting a sense of solidarity, kind of recognizing that we are all kind of in this herd, and kind of the immunity is only as strong as kind of each one of our contributions to it. So I think there is a lot of work that has to be done. And I don't know what the answer is, but I think it is trust, but also larger than trust.
Thank you. Devi, are the institutions that you both describe in the book, are they geared up, to pick up Gul's question, do they offer incentives for innovation towards cheaper, more effective solutions? I think this is...
Yeah, definitely. I mean, I think that Gavi's whole idea was actually to try to develop vaccines and then make them cheaper and offer them to countries. So I think but I would make a plea that actually we have a lot of solutions that already work, and we have a lot of things that we just, we're always trying to innovate and find new things, but they're things that we know work. So for example, do we need to be flying in toilets? They could be cheap toilets and kind of putting them into communities, or do we actually need to be thinking about water and sanitation systems and bringing clean water like we have done here? Do we need to be actually just thinking of how do we get our existing measles vaccine out across the world, or because children still across the world, die of measles, or are we going to chase the next thing? So I think there are a lot of existing solutions to problems that are not shiny, they're not fancy, it's not easy to show I've developed something, or but are kind of the harder work, but actually in the longer term, that's what we need. I mean, here in the NHS, the debates are not about vertical campaigns in the sense of should we have, this disease or that disease. We're talking about basic health systems and human resources, and those are the same debates we need to be having across the world, not about which campaign's coming in and how much money it's going to be, but actually how do we build a robust health system? How do we actually get health workers in that system who are trained, who are willing to work in difficult areas? And that would do much more, I think, to, in a sense, solving the global health challenge than just a pure focus kind of on innovation.
I completely agree with that. As you may have read, there's a lot of excitement around the malaria vaccine, partly because it's the first vaccine against a protozoa, so it is a big deal. So certainly there are areas that kind of call out for continued innovation, innovation that often requires, as it was true in this case, kind of leadership at a normative level by kind of WHO and kind of even by the UN itself, kind of multiple kind of research institutions being willing to work in a more collaborative way kind of with one another, and kind of the pharmaceutical industry. So all sorts of interesting things were worked out around kind of sharing IP, kind of sharing publishing rights. So again, things that may not seem innovative, but actually kind of were pragmatic innovations that were really important to kind of fueling this work and making it possible. So not to discount, kind of there are still areas that need innovation. We need vaccines that don't require a cold chain, right, so that they can be more easily transported around the world. Absolutely. But I couldn't agree more with what Devi said. I mean, just to kind of go back to Ebola, kind of more than $3.2 billion was invested kind of to stop the Ebola epidemic. Kind of back of the envelope calculations say about half of that could be used to build meaningful primary healthcare systems in the 3 affected countries. But we're just not set up to learn those lessons yet, unfortunately.
JP asked about public-private partnerships in health, and I think there's quite an ideological divide about them. What people are trying to capture in other spheres is all the speed and innovation of the private sector meets the public sector's legitimacy and ability to make trade-offs and make sure that everybody gets a fair deal. That's the ideal. And of course, but it can go horribly wrong. You can end up with all the sort of short-termist, profit-driven motives of the private sector married to the slow, bureaucratic, non-innovating public sector. So, you know, in global health, what's happening? Are we seeing the best of both those worlds coming together, or are we seeing a bit of the worst of both those worlds coming together?
Well, I think we're seeing kind of all of the above. And I will say, kind of, even though kind of the WHO is opaque in many ways, it has been very candid about kind of who it thinks should be in the room and why. So kind of, if we think about when Gro Brundtland was Director General and led the work on the Framework Convention for Tobacco Control, she made it very clear that the tobacco industry could not be part of those conversations, because the tobacco industry could kind of never make a legitimate trade-off that would ultimately kind of be hurting its bottom line, because her whole goal was to try to ultimately eradicate the tobacco industry. And if we think about kind of the Gavi model, Gavi, partly because it has kind of been focused not only on kind of shifting the kind of immunization markets from a kind of relatively kind of higher price and low volume dynamic to a much larger volume and kind of lower unit price dynamic, but also about catalyzing future innovative research, which it's really done kind of particularly on kind of the next generation pneumococcal vaccine. It is said it needs the vaccine industry in the room. It needs the vaccine industry to be able to be part of those deliberations, because similar to kind of what they look to their research partners, they need to know kind of what is really feasible given what we know now, because they don't want to be investing kind of $50 million to try to create something that we don't have the science yet to do. So kind of this question of public-private partnership has been answered in very different ways. And from the World Health Organization's perspective, kind of they only really have two categories. They have their member states, and then they have everyone else. So although kind of what happens in the tobacco situation is they get rid of kind of the tobacco industry as kind of a possible party to those deliberations, kind of in most of their kind of core deliberations, it's only member states, because they actually don't generally distinguish between a private company or a private foundation or an NGO. Kind of private to them means all non-state actors. So it's also kind of an interesting distinction that they make that I think often is not immediately perceptible to those of us who tend to think kind of private means a company and not necessarily an NGO or civil society actor.
Now, I know we're getting close to our closing time for this discussion. What's striking about this book is that it makes a compelling case that we need global health governance. Countries for the last 200 years have realized that infections travel, that health problems need collaborative solutions. And so the World Health Organization was created. But you know, this is a careful, factual book that is a bit depressing about the World Health Organization, right? So I'd like to end by asking each of you, what would you do with the World Health Organization? Should we just, you know, we've got all these other organizations that have been created to deal with its failures, really, if we're honest. There's now dozens of global health initiatives and organizations. So what should we do with the World Health Organization? Is there any part of it that's worth saving? And what's one thing you would do to try to, if it is worth saving, what would be a first step towards making it more effective? Sorry, it's not an easy question, but you know, you're the two people that can answer that one.
Yeah, I mean, we've thought about this a lot, because after Ebola, we were in a room, we were on a panel discussing kind of about what to be done, and there was this crisis moment of like, if they got it so wrong with this, and not much is changing.
2 years ago, we were quite optimistic, actually. I mean, in that room, like Debbie and I were like, this
we were
is the moment.
ones.
This is the moment.
And the older
people were like, oh.
You'll learn.
Oh. Oh. It's so sweet. You're so optimistic. We're like, no, surely they were right.
Yeah, but I actually think what the conclusion that we've come to is that we would need to invent it if it wasn't there. We don't need global governance for everything. There are a lot of things that can be handled at the national level, but there are certain things we need. We need governance for global public goods. We need it for problems we need stewardship, and the WHO serves that role, so how can we fix it? And I'll tell you why I think it hasn't reformed and why there's no place to do reform. So how are organizations managed, and what we discussed about is you have boards, right? Like institutions have boards, and the boards come together and they make decisions and they're implemented. So the World Health Organization has a World Health Assembly, which is member states come and give their statements, and you have an executive board. But the executive board over time has both grown in size and it's also grown in terms that the individuals were supposed to be coming in an individual capacity. You come as an expert, you're a medical expert, you come for the good of the institution, sort of independent. Now they're actually country representatives or even representing certain regions, and they read out prepared statements from their country or from their region. And so it becomes like a mini World Health Assembly. So actually countries don't talk to each other. I've sat through a couple of these. They actually just each kind of read their statement.
So what would you do?
You'd have to reform the executive board. You have to complete, and who does it? So they've tried to do this. So the Gates Foundation tried to fund, if you need money to do it, so they tried to fund a plan to reform this, and developing countries, and quite recently got outraged. They're like, oh, the Gates Foundation is funding the reform of our institution, and what are they going to fund it, reform it to a board that looks like Global Fund and Gavi, where they are voting members. So it's...
That sounds suspiciously like we need it, it doesn't really work, and it's not going to be changeable. Just give us an uplifting note.
Oh dear, okay.
No, not necessarily.
Okay, well, yes, all right. I think, to be fair to Margaret Chan, who is the current, although kind of soon to be former Director General of WHO, she said at that moment, she said, I completely understand why you're outraged. I have no money to form a reform process. I have no money to fund it. So if you, countries that are outraged, want to give me money to do that, please do. But in the absence of kind of voluntary contributions that are actually earmarked to help kind of strengthen the institution through a meaningful reform process, we have to look to the Gates Foundation or someone else who would be willing to fund that. And no one really stepped forward. But I do think it is important to have a World Health Organization, not only for the reasons that Devi mentioned, but also kind of in a normative standard setting, like what should health systems look like. WHO does some of this kind of with their essential medicines list, increasingly kind of with their work to articulate kind of what health workers in totality kind of should be able to provide at a kind of primary kind of to tertiary care level. So I think we certainly believe the WHO is important, but the WHO, despite its name, kind of the World Health Organization, and despite that kind of quite grand mission statement in its constitution, was never intended to be all things to all people kind of through the health landscape. At inception, it actually focused on only 6 things. And then over time, kind of driven by donor priorities, driven by kind of what was happening in the kind of global macro environment or kind of director general preferences, its agenda has just sprawled. So just a few examples on the positive side, and then I'll kind of give you what I think needs to happen. So kind of what kind of did it respond to because of a global macro kind of political moment? Well, in 1956, the Soviet Union walked out of the UN system. I'm sure kind of many of you have learned kind of in your PPP or international relations program. And right before it walked out, it had been about to sponsor a resolution at the World Health Assembly calling for the eradication of smallpox, because it believed from its own scientists that both kind of the science of kind of the new vaccine delivery mechanism were kind of good enough to really enable a coordinated effort to eradicate smallpox. All right, Soviet Union walks out, that doesn't happen. When the Soviet Union came back a decade later into the UN system, one of the first things it did was to co-sponsor something with the United States at the World Health Assembly calling for the eradication of smallpox. Very much kind of using health and the WHO specifically kind of to demonstrate its kind of grant of faith back into the UN system. Less than 15 years later, the world eradicated smallpox. Now, sometimes kind of the expanding agenda hasn't worked out as well. The US was really the driver behind the WHO kind of committing to eliminate malaria. The WHO, for all sorts of reasons, failed spectacularly to eliminate malaria. But sometimes, again, kind of areas of focus kind of driven by these more external forces have really made a difference. And sometimes what the Director General has chosen to focus on has also kind of really made a difference. I think kind of what Gro Brundtland kind of shepherded, kind of midwifed with the Framework Convention on Tobacco Control was pretty extraordinary. It's had huge implications around the world in terms of kind of how much nicotine can really be in tobacco products, how tobacco products can be marketed, kind of where they're placed on shelves so that children can't reach them. All of that, I think, really matters. So there have been successes and failures kind of in this sprawling agenda, but I think the world really needs it. So kind of what do we do now? I think one of the reasons the WHO has lost legitimacy is because when kind of there was this 4-month gap between kind of the first case that we now know of Ebola in Guinea in December of 2013 and kind of when it was formally acknowledged a few months later, is you actually had MSF and Partners in Health saying, we think this is Ebola. You had MSF, which has been in Sierra Leone since the Civil War. They have been there for more than 20 years, saying we are on the ground, we think this is happening. You have Partners in Health that has been in Liberia since its Civil War, saying we are seeing this, we think this is Ebola, we do not have the ability to test this, we don't have the ability to get the samples safely out of country, we think this is Ebola. And the WHO saying, like, that's just not what we're hearing from our government partners. And so understandably, that has created a fissure, or arguably didn't create, but kind of widened the fissure of faith kind of from the civil society partners and people on the ground kind of in the WHO. So I think we need to preserve WHO as a forum of states and by states and for states, but I think there needs to be more of a formalized process of getting kind of the major kind of civil society and non-state actors, but also kind of funders like the Gates Foundation to help set the agenda, which I think would help hopefully break this logjam at the executive board level while still preserving kind of what is unique about the WHO as kind of being the only kind of health-focused institution that still is constituted by its member states.
I think that's a lovely place to end. A reminder that we need a forum to which governments can come to deal with health emergencies as well as, you know, health chronic problems. And as Devi highlighted, we need governance reform in the World Health Organization, and you know, there you're right. And actually, what you both do in this book is you talk through how innovations in the governance of the new institutions can actually really work. And so I suspect that the answer to your issue on governance is, you know, read the book, because actually there are innovations which can help organizations be more nimble, reach out to different groups, provide solutions. So with that shameless plug for you to buy the book upstairs in the cafeteria, could you join me in thanking our two speakers? And then please feel very welcome to join us at the reception upstairs. Thank you all.
Thank you very much. Thank you, Anna.